Hi, I'm Stacey Tinianov, and I'm excited to be here as part of Survivor Journey's Survivorship Cancer 101. And today I'm going to talk to you about moving from cancer patient to cancer survivor into advocate. So in January of 2013, I was living and working in Silicon Valley. My family is in San Antonio, Texas. And I received a call from my mother that she had just been diagnosed with breast cancer. I took a leave of absence from my job and started flying back and forth from my family in California, my husband and two children, back to San Antonio to help her get situated with surgeries, with chemo, with radiation, with all of the things that come along with getting a cancer diagnosis and going through cancer treatment. And at that time, the entire experience was almost surreal. This is, these are words that most people don't hear of. Invasive ductal carcinoma, metastases, sentinel node biopsy, pathology reports. It was like learning a new language at a time when you are the most fearful and the most afraid. So it was challenging, and I became an advocate for her. I became an advocate so that she could feel seen, heard, and held as she went through her cancer treatment. But 6 weeks later, 6 weeks after that picture was taken, which was exactly 4 months after my mother was diagnosed, this was me. I had just had a single mastectomy. Because with my first mammogram, I had been diagnosed with breast cancer. And really, I moved from advocate for my mother into this patient role and realized pretty immediately there was a huge disconnect. There was a big disconnect with how healthcare saw me, which was kind of as a set of symptoms, a set of pathologies, genomic markers, genetic predispositions, and then how I saw myself, which was really actually a healthy, active, educated 40-year-old woman who also was a mother and a wife and a gardener, and didn't always follow directions, and really a control freak. And so for those of you who are seeing this and have been through cancer, control freak and cancer don't mix very well. So I found that I really needed to navigate my healthcare differently. It wasn't just about what is the standard of care for somebody who's diagnosed with breast cancer. It was about creating my own plan. It was about hearing what the best practices were, hearing what the NCCN guidelines said, and then asking the question, well, wait, if this is the guideline for a 65-year-old woman, why are we doing the same thing with a 40-year-old woman? We're very, very different. So I was advised that I needed a mastectomy, a sentinel node biopsy, 12 weeks of chemo, radiation, and then tamoxifen. All of this sounds very, very normal for most breast cancer patients, but I didn't feel like they were tailoring my treatment for me. So my plan involved finding a new oncologist, having that mastectomy and sentinel node biopsy, but then going down a path of really trying to personalize my treatment through science-based evidence, through diagnostic testing, through shared decision-making. And that was where I first found advocacy. It was really around self-advocacy. And then I was left with a bunch of unanswered questions and what I felt were lame excuses for why things were the way they were. Now, don't get me wrong. When a physician can look me in the eye and say, I don't know, I'm actually grateful. I'm grateful that they're not guessing. I'm grateful that they're not presenting something as fact when really we're really not very sure. But the lame excuses that I was hearing were things like, well, that's kind of just the way we do it, or there's no evidence to support that theory, or well, that's not really listed as a side effect in the literature. The worst one for me was when I would ask a question and they would say, well, Stace, we actually don't have enough data to answer that question. What I knew in my very, very, very short time in the cancer space, starting with my mother's diagnosis and moving into mine, was that there were over 16 million people in the United States alone that were living either with an active cancer diagnosis or post-diagnosis, 16 million survivors. In addition, we were getting 1.7 million new diagnoses, again, in the US alone. And so to hear something like, we don't have enough data to answer that question, really, really, really fired me up. We did have enough data. We just weren't sharing it, and we just weren't learning from it. I knew in my bones that we needed to have a paradigm shift, that we needed to start to look at things differently. But who was I? I was a 40-year-old cancer patient, young for breast cancer, but not a doctor, not a nurse. Who was I to talk about the shifts that needed to happen? But what I could do was I could share my perspective. I could say, this is how you see the situation in front of you, but this is how I see my situation. The doctor could say to me, well, Stace, this is what the guidelines say. And I could say, yeah, but where in those guidelines is it talking about premenopausal women? And we started to have conversations. I started to share my experience and my perspective, and slowly, slowly, slowly started to build relationships. So my path to advocacy really started with just sharing my story. From going from caregiver to my mother to, oh my gosh, I'm a patient, to, oh my gosh, the typical cookie cutter approach to treatment isn't working for me. And I know how to co-create a path with the care team. As I started to do this, I started to build relationships, not just within the healthcare institution, but with other patients, other survivors, people that were also experiencing something similar, that they were trying to be put into a box that just didn't fit them or just didn't feel right for them. And so I started to help those people share their stories, because again, a paradigm shift by one person is practically impossible. But as we all start to shift people's perspectives, that's when real magic starts to happen. And that's when people start to change their minds. And I like to say we change hearts and minds with every story, and we do. Everybody's story is incredibly powerful. I started to work with groups of healthcare providers, groups of fellow survivors, patients, other advocates, to identify gaps and propose solutions. And really, it was at that moment, the identifying gaps and proposing solutions, that I felt I moved into advocacy. Because candidly, it's really easy to complain. It's really easy to complain that this didn't work for me, or this is a broken system. But it's a whole nother thing to say, this isn't working, and what about if we do it this way? Not everybody says, yes, that's a great way to do it, but you start to get people thinking that we don't have to do this cancer thing the way that we've been doing it for so long. I really started to learn the language of healthcare, and wherever you are in your cancer experience, even if you've just been diagnosed, it is practically a new language. There's also a language that happens kind of in healthcare institutions. And that language is kind of frustrating for some patients. We hear things like the value of care, and value to a patient, to me, to an individual, is one thing. Value to a healthcare institution oftentimes comes down to the bottom dollar. And while that's frustrating to think that there's a price tag on our lives, it's real, and it's something that we need to acknowledge if we want to move the system. We need to speak in a language that resonates with who we're speaking with. I started to ensure that everyone was represented at the table. Again, I felt coming into breast cancer at the age of 40, over 20 years younger than the average diagnosis, that my voice hadn't been taken into consideration when we started to talk about protocols, when we started to talk about guidelines. But as a white middle-class woman, it was very easy for me to see there were so many other voices that weren't represented. People of color, men with breast cancer, people who live in rural areas or who don't have health care. All of those voices need to be represented. And if the individual themselves can't come to the table to share that, then we have to find a way to bring that voice to the table for them. Definitely not accepting the status quo. I think the most frustrating phrase for many of us is, well, we've just always done it that way. Just because we've done it that way doesn't mean it's the best way to do it. And so pointing that out kind of was eye-opening for a lot of people. And then I think it's really important to, when we talk about changing the system, talk about seeking durable change, not just a Band-Aid or not just a fix for me. I can certainly create a path to shared decision-making for myself, but if I'm really going to fundamentally change the system, if I'm going to go after that paradigm shift, I have to make sure that somehow something has changed institution-wide so that shared decision-making will be available for every patient that comes after me. Bottom line, there's more than one type of advocacy. And what I shared with you in the beginning around creating my own healthcare team and identifying my own goals of treatment is really self-advocacy. And it's something that everybody can do, but it's not always easy. And not everybody wants to do it. So if you're ever in a position where you don't feel like using your outside voice, you don't feel like fighting for what you know you need or deserve, then think about appointing somebody to do that for you, whether it's a spouse or a friend. We all need advocates. And sometimes the hardest thing is to be an advocate for ourselves. Patient advocacy, community advocacy, research advocacy, policy advocacy, there's probably like 1,100 more flavors of advocacy, but these are the big nuggets. And I just wanted to give you a little bit of a preview and snippet of what those entail. So with the self-advocacy, it's really about you. It's about yourself. It's about helping to build the right care team for you. It's about helping to build a personalized screening plan, personalized care, personalized survivorship support. And a lot of it focuses on shared decision-making, making sure that you have a voice and making sure, again, that you feel seen, heard, and held in this whole experience. And where do you self-advocate? Anywhere, everywhere. Obviously, your physician's office is a good place, from your hospital bed sometimes, your medical center and leadership, and then even outside of healthcare. As you are going through cancer treatment, as you are coming out of cancer treatment, and maybe sometimes as you're going back in to cancer treatment, friends, family, the workplace, there's a lot of places where being able to advocate for yourself and your needs is critically important. And then the why you do it is pretty obvious with self-advocacy. You want to get the right care and the right support at the right time for you. Patient advocacy is a little bit different, and this is probably the broadest one. I think anytime we talk about the patient experience or try to change the narrative for the patient, a lot of times people just refer that to as patient advocacy, and that's fine. It is very, very broad. Individuals can support individuals one-on-one as an advocate. And you can do that casually, you can do that formally. Again, if you're watching this and you have had a cancer diagnosis and you have been public about it, sometimes in your community, you might be the first person somebody calls or emails and says, I've got a diagnosis, what do I do? Helping them navigate that is actually helping them advocate, whether it's helping them learn how to self-advocate or helping to advocate for them. I think the easiest, I shouldn't say easiest, I think the lowest barrier to entry to patient advocacy is simply sharing your story. And the reason it's not the easiest is it's hard sometimes. It's hard to be vulnerable. It's hard to put yourself out there and say, this is me, and it's not neat and it's not pretty. But it is something that everybody can do, and everybody's story is incredibly powerful. You can help others share their stories. And if you're really feeling the outside voice, take a seat and be a voice at the table. And you can do this in a variety of ways. Most health institutions have patient advisory councils. You can join one of those and advocate for an improved patient experience. Anytime you get a post-care survey, healthcare institutions are legally responsible to put these out to their patient community, and they're graded on them. So fill those out and share your experience, whether it be positive or not so positive. Media, social media, there's a lot of places to advocate for the patient experience and changing the patient narrative where applicable. Community advocacy is incredibly broad. Again, community is defined really by the community. You could call the cancer community a community group. You could call your zip code a community. Maybe it's your house of worship and that group, or school, or all of the different flavors of community. There's a place for advocacy within that. And sometimes it's even pre-cancer. A lot of community advocacy involves health and wellness screening, how to destigmatize things like mammograms or colonoscopies, or how to make people more comfortable with things like HPV vaccines, so that we can avoid as much as possible new people having to come into the cancer community. Again, where you do it, anywhere in your community, but you can do it through local healthcare institutions, schools, libraries, faith-based organizations, traditional media, social media, anywhere you can get the word out that really starts to drive home the concepts of health equity and improved outcome in the identified community. This is really a great opportunity, especially when you start to think about opportunities for risk reduction. Being able to elevate the community health and disease literacy is huge. And oftentimes the best people to do that are the people in the actual community. So if there's a group that you belong to, you are probably a trusted voice. Getting the word out in that community is huge. Research advocacy, people tend to be either hot or cold on. If you've had a cancer diagnosis and if you've taken any sort of treatment, you have benefited from the decades and decades and decades of research advocacy that has happened. Research advocacy is about promoting research, whether it be in a specific cancer type or whether it be in a specific demographic. It's about promoting relevant research. So we could probably have more studies on how yoga helps people recover and helps de-stress. And while that's wonderful, we only have so many research dollars. So what do you want to know? What does your cancer community want to know? What does your general population community want to know? Research advocacy can help you identify that and promote that. Within cancer, it's really critical. Research advocacy helps support the design of research and clinical trials. If you're not familiar with clinical trials are the way that therapies get approved. So this is not just about chemotherapies. This is also about techniques in radiation, surgical techniques. Clinical trials require research, and clinical trials, by and large, really struggle to get enough participants to actually move forward. So if you are interested in research and accelerating research or being very specific about how we drive research, research advocacy is a great place to start. Health and academic institutions regularly have research efforts going on. Funded research projects and programs really can kind of come from anywhere, through an advocacy organization, through a health institution. There are some organizations. PCORI is the Patient-Centered Outcomes Research Institute. There are opportunities for patients and survivors, no degrees necessary, to get involved in that kind of advocacy. And so if you're interested in it, definitely think about it. And policy advocacy, again, people either love it or hate it. Back a few slides ago, when I talked about ensuring that there was durable change, this involves policy. So for instance, again, love it or hate it, but the Obamacare, that was a huge policy advocacy lift. People needed healthcare, and people who knew that people needed healthcare got on the phone, they wrote letters, they sent emails, they visited Capitol Hill, and they advocated for policy changes to make sure that those laws were not repealed when they were up for repeal. Basically, it's about evangelizing for things that will benefit in the cancer space, that will benefit cancer patients and cancer survivors. We do a lot of evangelization for protections for patients. If any of you have had any sort of genetic testing, one of the reasons that people can feel a little bit more comfortable with genetic testing is because of the Gina Act. And basically, this act is the it refers to the Genetic Information Non-Discrimination Act. And so what it says is, if you were to have genetic testing and somebody were to find, the lab were to find a mutation, you can't be discriminated against that from a receiving healthcare coverage standpoint. And that's critical, because without these protections in place, cancer patients might not want to know what their genetic makeup was. And again, if you've been in the cancer space, you know that a lot of the treatments that we have now can be tailored based on germline and somatic mutations. Policy advocacy can happen anywhere. Health institutions have policies, visitor policies, follow-up policies, policies with access to survivorship care plans. Policy happens everywhere. Advocacy organizations are a great place to get involved with, whether it be your cancer type or something like the National Coalition for Cancer Survivorship. These organizations help bring all of the voices together to really drive policy change. But your local government, your state government, your federal government, anywhere that creates policy, you can do policy advocacy. So putting my advocacy pieces together, I didn't just start doing all of it. I started really with, actually, I guess I started with the patient advocacy, right, with my mom. And then 4 months later, all I could really focus on was my self-advocacy. And then, you know, coming back to the patient advocacy, I spend a lot of time connecting with patients and amplifying patient voices on social media. Obviously, there's the platforms that everybody's aware of, Twitter and Facebook, but then there are some very quiet and private platforms where you have to have membership to be a part of. So I participate in those, and again, help people find their outside voice so that they can be self-advocates, and so that we can all start to collectively change the patient narrative. Member patient advisory councils, I mentioned that a little bit earlier. Reach out to your health institution and see what they have. If they don't have a patient advisory council, create one, because you know what? They could really benefit from understanding what their patients need, what their experiences are, and how the patient voice can help them change some of their policies and practices to to improve patient satisfaction and patient outcomes. The gobbledygook there with the letters, SABCS, ASCO, AACR, those are all just acronyms for conferences. There's a lot of conferences, and any cancer type that you're affiliated with will probably have its own conference. But ASCO is the American Society of Clinical Oncologists, and they get together annually. There's a whole advocacy room. There's a whole advocacy plan. Advocates are definitely invited, and there's no knighting that happens that says, "Ooh, now you're an advocate and now you can come to this conference." If you're interested in this stuff, you're welcome to come. I did go back and get a board certified patient advocate certification, mostly because I was interested in what that entailed. And so there are advocates who walk people through their own process. And for that, they wanted to create something that really gave people a little bit of credibility. And so the board certified patient advocate is a test. It's a 3-hour test that basically says, test your medical knowledge, test your insurance knowledge, and then test your general knowledge of what it means to help advocate for and with somebody. So again, if you're interested, you can do some work on that. Research advocacy, policy advocacy, community advocacy. Again, these were all pieces of a puzzle, but it wasn't really linear. And this is just an example of what my advocacy pieces look like. Again, self-advocacy, patient advocacy, and then sometimes you find a project that involves all three, research advocacy, patient advocacy, and community advocacy. And you can see as I kind of move through this process, at one point in time, I go back just to self-advocacy. So every year when I go back to the oncologist, the only thing I can think of is, what about me? What about me? What about my health? What does this mean for me? And I get through that, and knock on wood, everything is clear. Now I can move back into advocating for others and advocating for change. And so again, if you're interested in this space, allow yourself the space and the grace to kind of move around and do what you need to do for you. Everybody should have goals. These are a few of my advocacy goals. Patients and survivors, let's move from us as subjects and consumers and customers. Let's move us to people and partners in our own health. Very, very fatigued, even just in the short amount of time that I've been in this space, to see this incremental progress in prognosis, especially for individuals with metastatic disease. And incremental progress really in outcomes across all cancers. So I really want to move us into this exponential improvement in outcomes and quality of life. Because again, just because you have a drug that will work and keep cancer at bay doesn't mean that you are actually able to take advantage of living life. And so the quality of life piece is critically important. There is this increasing incidence across cancers, increasing incidence of diagnosis across all cancers, and the age of diagnosis is decreasing. And so again, a goal of mine, a goal of the whole space is to really start to, how do we push out more risk reduction behaviors and changes so that we can reduce those numbers of cases. Huge mortality differences. When we talk about health equity, it's not just about access to care, it's about outcomes. So if you are Black and you have a diagnosis of breast cancer, you are 40% more likely to die of your diagnosis than if you were same cancer, but you were a white woman. So health equity is a huge, huge, huge issue in the cancer space. There is a higher mortality across the adolescent and young adult, as well as the BIPOC communities. So I think we need to move into these improved outcomes across every space and really drive health equity. And then one of the big reasons we're here, there is such a lack of post-treatment support across every cancer type, despite the fact that we all should be going home with survivorship care plans if we're fortunate enough to get a diagnosis of no evidence of disease following a diagnosis of cancer. So really driving access to survivorship support for all individuals with a diagnosis or history of cancer is another one of my goals. This is what it actually looks like. It's super messy. So I'll go back. This is nice and streamlined. And you're like, oh yeah, great, going from here to here. It never looks like that. We start to make great strides in some spaces, and then we go completely backwards in others. COVID has really done a lot to kind of change this trajectory. In some cases, COVID and being at home and the health institutions moving more towards a telehealth platform has been wonderful. It's been wonderful for a lot of people because it's given them access that they otherwise wouldn't have. But COVID, on the other hand, if you needed to get in to surgery, if you needed to get in for an infusion, COVID really started to push those things back. And so people's health and people's outcomes really started to take a dive. And I think things are kind of coming back now. And hopefully we'll be able to maintain what we liked from COVID, the remoteness, the telemedicine, the point of need as opposed to people coming in. And hopefully we'll be able to get back on track with some of the other things. So the advocacy road is windy, and it is paved really with this common desire to educate and to learn. And that's really huge, because if you come into this space, you know a lot, and you should absolutely share what you're willing to share, but also be open, because everybody's experience is different, and it's that collective experience that we really need to get behind to drive the change. Huge urge to innovate in this space. I think most of us know that not everything is working as well as it could be. And so figuring out what could be better and what could be better for certain groups of people is critically important about, personalizing the experience. Really large push to ensure that while the systems that are in place to protect patients continue to protect them, that they don't continue down a paternalistic road, right? We are done with the days where an individual has to walk into the doctor and just take whatever they've said to them. It's okay to ask your doctor why. It's okay to go into your doctor with a stack of research articles and say, I learned this, can we talk about it? And honestly, if your physician isn't ready to have that conversation, it's okay to find a new physician. It's important to know that this advocacy road is also paved with some challenges. There are data and knowledge silos, and not all of that is based on technology. There remains a good bit of paternalism and a good bit of ego in the healthcare space. And so just know that, because I think in knowing that, then when you come up against it, it's easier to deal with. There are status quo challenges, and there are things that move at a glacial pace, and healthcare is one of them. Healthcare still uses fax machines. It is 2021. There are financial constraints in the sense of most advocates don't really make any money with what they do. Research is a little bit different. If you get on a funded project, then there should be monies for you. Advocacy organizations are a great place to start with some of that. A lot of them have scholarships that you can apply for to go to conferences and things like that. But I think the biggest thing to know if you're going to stay in the cancer space and get involved with advocacy is there's grief and there's loss, and it's going to happen anyway. But when you make your community a group of cancer patients, cancer survivors, cancer thrivers, cancer mesters, you are going to lose people in that community at a rate higher than you would likely be losing them if you were to just stay in your non-cancer world. But this is what they look like. This is just a snapshot of individuals that I've managed to meet and connect with and befriend over the last handful of years. All of these pictures, most of these pictures were taken at conferences. Those are really the times that we get together and connect and learn. And it's great. It's great to learn with a group of people, dig through research together, and then bring it back to our own communities. And what you should know, find your people. When I got into advocacy, my people were not breast cancer people. They were actually lung cancer people. Lung cancer was laser focused on getting rid of the noise and really driving change. And that's what I wanted to do. And now when I advocate across cancers. And I think that's been really, really rewarding for me. Make sure you're listening to identify the gaps and challenges. You have your own personal experience. And again, that is invaluable. Share it, share it, share it. But there are other gaps, there are other challenges. Listen to those, because all of these things need to come together to really change the narrative. Think about what your strengths are, but think about what your interests are, because again, you can help probably in a lot of places, but where do you want to help? What do you want to change? What do you want to do? Words matter. Even the word survivorship, which sounds to lots of people like this beautiful, amazing place to be, right? You go from patient to survivor. That word doesn't resonate with everybody. There are people with stage 4 cancer, terminal cancer, that don't feel like survivors. Technically, they are, based on the definition of you become a survivor at the point of diagnosis, but that word matters to them. So listen and hear what other people think, and how other people want to be called, what they want to be referred to as. Everyone can be an advocate, and I mean that. Every single person who watches this, every single person who has cancer, people way outside of the cancer space, everybody can advocate. There's something that you can do to push this needle forward. But advocacy itself is not for everyone, and that's okay. Kind of that leads into the self-care part. Advocacy can be exhausting and it can be slow. And if you are passionate about something and it is moving too slowly for you, sometimes that can be challenging. So think about it, dip your toe in it. You can always come back out. You're not committing to anything. Your voice is really, really, really important. Your experience, whether you have a very common cancer that hundreds of thousands of other people have, your experience is unique. Your set of circumstances is unique. Your life and your life experiences that you bring into that cancer space is unique. So if you can, and if you're comfortable, definitely share your voice, share your story, so other people can learn from you. With that, I just want to thank you for your time, and now, later, anytime, I am happy to answer questions or you know, entertain thoughts from people who think they might want to get involved in advocacy.